Good afternoon, this is Alena Skalova and I have two cases for you. The first one is a consult case from Portugal, and it was an invasive tumor located in the nasopharynx. This is a scanning magnification of the tumor. You can see that there is a lot of hyalinized stroma component and invasive structures of a tumor, which I will show you in high magnification fast. So here we have the tumor. There is a vascular layer, so the tumor grows very deep in the nasopharynx and parapharyngeal area, and it has been sent with 3 diagnoses. The tumor surprisingly showed in Portugal P16 positivity, so the question was if it could be multiphenotypic HPV-related tumor. The other possibility suggested by the pathologist seems to be also quite interesting, and it's possibly myeloepithelial carcinoma or adenoid cystic carcinoma, but the pathologist was not very happy with this idea because, as you can see now, the tumor is biphasic, but the epithelium, at least the luminal part of the epithelium, is pretty eosinophilic. Here we have a typical place. So it's biphasic tumor, and then a little bit about the tumor. It was SOX10 positive, completely SOX10 positive. This is probably better. It was P16 positive even in our place, but then we did also some kind of other stainings, and I need some time to find it. The structure is not very well preserved, but here we have the tumor, and this is CK7, which shows. This is P40, which shows positive staining in the abdominal layer, and again, as you can see, pretty small structures, biphasic tumor, very invasive with perineural invasion. So that was P60, P40 and P63, and CK7 quite opposite, not surprisingly showed staining, limited staining in these eosinophilic structures, the luminal part of the tumor. So what we did, we sent it for molecular testing, of course, to exclude possibility of that multiphenotypic HPV-related tumor, and it arrived back with presence of HPV, but type 143 skin beta types, which is low serotype. But we received the result of fusion MIP and FIP. So finally, it turned to be adenoid cystic carcinoma with unusual morphology, and these located in nasopharynx, oropharynx, and so on may be grouped in under the designation. And now please show me the paper called adenoid cystic metatypical. So this is adenoid cystic carcinoma with striking tubular hypereosinophilia, which we, with Martina Baničková, we collaborated in this paper, and I believe that this is exactly what we are looking at. And now, I mean, can you show me how to move with this? College chem. Yeah, college. Yes. So there is not so fast. I mean, the pictures may show, at least some of them may show this one, and it would be nice to have it high magnification, which is here. Yeah. Yes. and even better. So this is a paper, first paper on this, not entity but variant. If you look in to this middle one, so that's what we have in our tumor, eosinophilic structures in the luminal part of a biphasic tumor patterns. And in this paper, we already had both canonical fusion NFIP-MIP and non-canonical fusions with EWSR, MIP, and FUS-MIP. So this is a subtype of adenoid cystic carcinoma, which typically affects nasopharyngeal locations. In this case, that was a tumor primarily located in nasal cavity and with extension to nasopharynx. Not very good tumor to have. So that's my first case. The second case is a routine biopsy, which has been sent to our department, and because it is a little bit rare, I would like to show it. 70-year-old male, the specimen is duodenum. The sample was 9 by 8 by 11 millimeters in diameter, and it was polyp in duodenum. And for the first moment, you can see that the structure is hyperplastic. We have, could it be hyperplastic polyp or something like that? We looked at this specimen with Marian Schweidler, and he was the first one to say that hyperplastic polyps are not common in duodenum, and so we looked better, and we saw other structures also. These are very nicely differentiated structures, but in the tops of villi, you may notice somewhere, I should mark it better, but there were dysplastic changes, at least maybe here there is a possible to see dysplasia, somehow low-grade dysplasia. So basically, it's not hyperplastic polyp; it's adenoma. So this is a tumor. It's a benign adenoma of duodenum of foveolar type, and it does not need so much, but we did immunohistochemical staining or MUC5, which is nicely positive. Negative control on the normal mucosal surface. So this is MUC5 in a very short message, foveolar type of benign adenoma of the duodenum. And here there is a normal mucosa of duodenum. And now for a short moment, show please the second paper, which is quite nice paper, which I can recommend. I read it after having this biopsy, pathology of gastric and duodenal polyps in histopathology, where this foveolar type of duodenal adenoma is mentioned, and all the other variants as well. So that's all from my side today.
Like young gastrointestinal pathologists.
I'm sorry, that was an really easy biopsy, but I think we should also show rare and easy routine biopsies here.
So the point is never diagnose hyperplastic polyps in duodenum. I mean, they exist, but they are exceptionally rare, and probably if you are thinking about hyperplastic polyp, it will be foveolar type of adenoma.
Good afternoon, this is Keda Michalova. I have 4 cases for you. The first one is from endometrium. It was a consult biopsy sent with the diagnosis of endometrial polyp, and the lady was 53 years old. and here's what we see. I think this is quite easy case to diagnose. The architecture is quite typical. It is similar to Phyllodes tumor of the breast. And when we see this architecture in endometrial polyps or in cervical polyps, the first impression is adenosarcoma, which was the case here, or the diagnosis here. The only not very typical thing in this biopsy is the character of the stroma, because adenosarcoma is a mixed epithelial and mesenchymal tumor, with the epithelial component being bland and with the mesenchymal component being spindle cell with typical features of tufting of the neoplastic cells around the glands, and this feature, because there is a pseudodecidualization in the stroma, is not very well visible in this biopsy, and also the atypia which are present in these spindle stroma cells are not very well appreciated here because of the pseudodecidualization. But otherwise, the features are of adenosarcoma. First, the architecture and also the cytology is not in contradiction with the diagnosis of adenosarcoma. Regarding the so-called subtype of adenosarcoma, this is a low-grade one. There is a more or less 50% of the glands and 50% of the stroma. There is no stromal overgrowth, which is considered as one of the adverse prognostic factors, and the other one is a deep myometrial invasion, which we for sure cannot assess from this kerata, and also the high-grade cytological atypia are not present here. So the diagnosis here is adenosarcoma of the uterine cervix with pseudodecidualization in the stromal cells. There were many immunostaining performed from the sending pathologist, but it is not required for the diagnosis. The second case is also from endometrium. It is a 43-year-old woman, and here is what we see. And the diagnosis or the question from the referring pathologist was rule out an endometrial intraepithelial neoplasia. So here we can see the irregularly proliferating endometrium, maybe with early secretory features, and the areas, the questionable areas, are here. The first one. And the similar one is here at the bottom of the endometrium with contact to myometrium. So here in these areas we can see back-to-back glands, which where there are much more glands than stroma. The back-to-back arrangement is also alarming, but otherwise the cytological features are not very typical for endometrial intraepithelial neoplasia. And when we need to, or when we want to perform to make the diagnosis of AIN, there are three main conditions required from the morphological standpoint. The first one is stromal, or the gland to stromal ratio, where there are more glands than the stroma. The second is the size of this suspicious area more than 1 millimeter. Both of these conditions are fulfilled. And the third one is the presence of cytomorphological atypia, which is not present here. The glands here are they have subnuclear vacuoles, and they rather look like secretory type endometrium. So the third condition is not fulfilled. The only exception when these three conditions are not required for the diagnosis is when the patient undergoes some hormonal therapy, for example with progestin. Then the cytological atypia typically diminish. But regarding the clinical information, this patient did not have any hormone therapy. Then if not all of the morphological criteria are not fulfilled, you can help yourself with some immunostainings. And the three main are beta-catenin staining. This is beta-catenin, and you need to have aberrant staining in the questionable areas. Aberrant staining means that there is nuclear and cytoplasmic staining, which was not here. The only areas in the cells which are stained are cytoplasms and membrane. It is not nuclear aberrant type of staining. So this is normal. Another staining is PAX2. And in the areas of AIN, it should be lost, and it is retained here. And the third required staining is P10. And in the case of AIN, it should be lost, which is here. You can see the retained staining in the surrounding endometrium, and the loss of staining in the questionable areas, and also with another one which was here. So now we are still hesitating if this is an AIN or not, because there are not all of the morphological criteria fulfilled, and not all of the immunophenotypical features are fulfilled. I'll ask you for the reprint. This was finally the diagnosis here was non-neoplastic endometrium, because for the diagnosis of AIN, if not all of the already mentioned morphological criteria are not fulfilled, then you have the immunostainings P10, PAX2, and beta-catenin, and all of these three has to be aberrant. So you need in morphologically unequivocal cases aberrant staining with beta-catenin, aberrant staining with P10, and aberrant staining with PAX2. And if you have only one aberrant marker, then it is recommended not to make a diagnosis of AIN, and rather stick with benign or non-neoplastic condition. It can happen that it still goes to endometrial intraepithelial neoplasia, but the negative predictive value is quite reliable. But still, the patient should be followed up, and the biopsy should be repeated in a few months to confirm if there is still no neoplastic condition going on. So the diagnosis here was that this is an endometrium not fulfilling diagnostic criteria for AIN, so it was non-neoplastic, but recommended for the clinician to follow the patient and repeat the biopsy in a few months. Another case is 56-year-old man, and this was sent with the diagnosis of fibrosis of ductus deferens. So it is from the testis or from Funiculus spermaticus, and the questionable areas were here. Here we have structures of Funiculus spermaticus, which is normal, and here there are more rather small glands, which were not clear for the referring pathologies what this is, which is not weird because these lesions are quite rare, and usually they are not biopsied because they do not form any mass. But in this case, it was clinically symptomatic as fibrosis. So here we have few tubular structures which have cytologically blend features with columnar epithelial cells. Some of them were ciliated. So from the morphological standpoint, nothing suspicious for malignancy, but it is good to know what this is. So immunohistochemically, this is PAX8. Here. PAX8 was positive in these structures. As well as was CK7 here. Mesothelial markers were negative. Ferritin and WT1, and sulfur was negative as well, and I ask you for the picture. The diagnosis here was that these are embryological arrest, and especially the diagnosis here was paradidymis, so the embryological remnants, which are quite frequent in the paratesticular regions. The most frequent is appendix testis, which is most frequently symptomatical because it can undergo torsion and an infarction. This appendix testis is a residuum from Müllerian ducts, and there are more remnants from Wolffian ducts surrounding the testis and testicular adnexa, one of which is paradidymis. As I said, usually these structures do not form any mass, are asymptomatical, so they are not biopsied. So the diagnosis here: embryological residues of paradidymis structure, no malignancy or no tendency to malignancy, just like in the spectrum of normal. So that was it. And my last case. It is also from the testicular area, but it can also occur in female genital tract, for example, in fallopian tube or in the uterus. And in the testes, these lesions are most frequently in testicular adnexa. This tumor is not very typical from the morphological standpoint for what this is, because typically when these tumors look in a textbook fashion, they have so-called intercellular or bridges between the tumor cells, but sometimes they can also have eosinophilic cytoplasm, and when you see this lesion in the testis, you can, in this case, quite easily mistake this lesion from sex cord stromal tumors, especially from Leydig cell tumor. As for immunophenotype, this lesion was positive for D240 podoplanin, So this is adenomatoid tumor, the oxyphilic variant of adenomatoid tumor. So this is a typical immunophenotype. Sex-cord markers are negative. And if we go back to morphology, even if you do not have the typical mesothelial bridges in between the cells, there is one quite typical feature which is much more frequent in male genital tract than in female genital tracts, and it is the presence of lymphoid follicles, which are probably the result of lymphostasis in these cases, and these are present in almost 100% of the cases in male genital tract, and they can be diagnostically very helpful even in these not very clear morphological cases. It is interesting that despite the same origin in the female genital tract, these lymphoid follicles are quite rare, or rather rare, in female genital tract, being present in less than 20% of the cases. So it is not very helpful in female genital tract, but in male genital tract, the lymphoid follicles can help you to order the right immunohistochemical markers. So adenomatoid tumor is the diagnosis of my last case, and I thank you for the attention, and up to Marianne.
Good afternoon. My first case was a 81-year-old gentleman with a tumor of epididymis. So here is the scanning magnification. The tumor looked pretty well circumscribed. On this low power, you can see there was some myxoid stroma, some adipocytic differentiation, and some area without any adipocytes. So, moving on higher power, you can clearly see some prominent atypia in the non-lipogenic areas. And if you go in the lipogenic areas, you can see relatively bland spindle cells, or mildly atypical spindle cells, multiple lipoblasts in some areas, which are not very important, but are somewhat helpful. So in this location, at this age, with this morphology, what would be the most likely diagnosis? Anybody has a guess? It's an easy case. So before the era of immunohistochemistry, this would be signed out. Well, it wouldn't be signed out as dedifferentiated liposarcoma, maybe because it wasn't sure whether this wouldn't be some spindle cell liposarcoma, but it doesn't matter. I was thinking of calling it just dedifferentiated liposarcoma and moving on, but then I was like, let's make sure it is what it is. Crazy things happen today. So I did MDM2 immunohistochemistry. Just expecting it to be diffusely positive and finally signing it out. I got this result. This is actually the repeated MDM2 immunostain, which actually showed some cells with positivity, but the first MDM2 was completely negative with positive internal control. I got surprised because usually you get at least some staining like this. So I was wondering about other potential differential diagnoses, and the only one I could think of was lipoblastoma, some weird lipoblastoma. So I did PLUG1 immunohistochemistry, and this is PLUG1 diffuse strong or quite strong nuclear expression. So I was intrigued this might be actually some weird malignancy arising in lipoblastoma, but still it was old gentleman, typical location for dedifferentiated liposarcoma. So I did MDM2 FISH and it came back clearly positive for amplification. So this is still dedifferentiated liposarcoma. Just with immunohistochemistry usually works well, but sometimes it's tricky. So if there is a high suspicion of DDIF liposarcoma, just make sure you confirm with fish with unexpected findings on immunohistochemistry. So this is really perfect. So adipogenic area, sharp demarcation to non-lipogenic, highly atypical spindle cell sarcoma. Old person.
So the rule number one is common things are common.
Yes. Even if the immuno doesn't support it. If you can choose other means to support your diagnosis, go for them. Another case was a 80-year-old lady with a tumor on her back. The submitting diagnosis was a potential MPNST. Is this malignant peripheral nerve sheath tumor or not? We got these little fragments, which consist basically of spindle cell sarcoma, occasionally with some more pleomorphic cells, but generally relatively uniform. And this is actually pretty good morphology for malignant peripheral nerve sheath tumor. But then there's this. So there's some pigment. I didn't test whether this is hemosiderin or melanin. Might be both, actually, but what is important is the cytomorphology of the cells here, which changes quite significantly. They are more epithelioid or rhabdoid, with prominent nucleoli here. This is perfect area. So obviously this now the differential number one changes to melanoma with like a spindle cell component or transformation. So I did immunohistochemistry. S100 was diffusely positive in both areas, which would be so diffusely positive. S100 is very rare in MPNST actually. The same for SOX10. And H3K27, which is often lost in MPNST, was retained. And then I did HNB45. I forgot to ask for the red color, but still I think this is clearly positive, even though we have the melanin pigment in between. This is just unquestionably positive. HNB45 melanin was the same. PRAME was positive, and I'm still waiting for the results of molecular testing to confirm it, but I did RAS immunohistochemistry, and it's nicely positive in the epithelioid or rhabdoid component. So this will most likely have a RAS mutation and RAS mutation. Interestingly, it's kind of faint or negative in the spindle cell component, or a little bit positive maybe, but if I had just this, I wouldn't be sure how to call it. So this is most likely a dedifferentiated melanoma. Here we can use the term dedifferentiated because we have the well-differentiated component here transforming into the undifferentiated spindle cell component with loss of some markers, HNB45 mostly. So it's not perfect dedifferentiated like melanoma actually. The immuno isn't lost completely. Another case, this was a 65-year-old male with a rapidly growing tumor in his axilla. First biopsy I got was completely necrotic, and it looked like this basically, even more necrotic. I could see just the shades, the silhouettes of the necrotic cells. That was it. So I said it's a malignant tumor most likely, but we need more material, and so he was rebiopsied, and we got this undifferentiated epithelioid horrible tumor. Again, very prominent nucleoli, very high mitotic activity, atypical mitosis, huge areas of necrosis. So again, in axilla, old man, number 1 diagnosis would be melanoma. Number 2 would be probably pulmonary adenocarcinoma or undifferentiated carcinoma of the lungs. But cytokeratins were completely negative, as was actually everything else here. HNV45 S100 substan was negative, so we did molecular. There was a BRAF mutation, methylation pattern was that of melanoma, and there was high tumor mutational burden as well, so perfect constellation for undifferentiated melanoma. So here, this is true undifferentiated melanoma with loss of expression of everything. Unfortunately, the gentleman died very soon afterwards. Oh, this one was very interesting. It was a 25-year-old female with a lesion on her elbow. It was supposed to be a rapidly enlarging lesion with like 3 centimeters in diameter. See some polypoid skin excision, unremarkable, and then this. So at this age, 25-year-old, of forearm, so extremity, a rapidly enlarging lesion, and with this amount of lipoblasts, the first thing that came to my mind was, is this myxoid liposarcoma? So I stained for DDIT3 immunohistochemistry, which should be positive in basically all cases. It was completely negative in all the cells. I did also S100 to make sure these are actually lipoblast and not some signaturing cells of some metastatic carcinoma, but it seems to be adipocytes because it's S100 positive. Cytokeratins were negative. To make sure, I also did FISH for DDIT3. Plug1 immunohistochemistry and FISH was also negative. And then I looked back at the documents, and there was by hand written like addendum that the patient has been given local corticosteroids for treatment of I don't know what, some skin dermatitis. And so this is most likely fat atrophy after corticosteroids, which is a well-described phenomenon. Local injection of corticosteroids can lead to atrophy of musculature, of skeletal muscles, of the adipose tissue, as we see here, and also it leads to depigmentation. So this is actually a nice case to remember. Occasionally, this is getting. I wonder whether this is like the remnants of the injection. This is eosinophilic stuff. I don't know. So next case was a 33-year-old male with an osteolytic lesion in the ischium, in the pelvis. As it happens, in recent years, all we got were these wonderful samples of skeletal muscle and tiny, less than 1 millimeter sample of this tumor. Luckily, I think the morphology is very typical for a tumor called chondromyxoid fibroma, which is a very well defined and described entity in the bone, typically consisting of this relatively hypocellular proliferation of spindle to stellate cells in a kind of chondromyxoid stroma. Perhaps you can see this gray-blue chondroid. It's called aura. Kind of like a hint that there is some chondrogenic differentiation. Also, this thin-walled vasculature is typical. With such a limited sample, it's very important to correlate the morphology with radiology, but the radiology was perfect for it. It was osteolytic lesion, very well circumscribed with sclerotic border. And also I did SOX9 immunohistochemistry. SOX9 is a marker of chondrogenic differentiation, which is typically positive in chondromyxoid fibroma, and it showed nuclear expression as it should do. Otherwise, the molecular background of chondromyxoid fibromas is known. There are fusions of GRM1 gene, and there is a very good immunomarker for this tumor, which is typically positive. But these tumors are so rare, and we get so few bone biopsies that we just didn't buy it. It would be cheaper for us to do molecular once in 2 years or once we have this tumor. So last case was adult person's tumor somewhere on his buttock, I think, soft tissues. And we got this nodular tumor, relatively well circumscribed, at least here. And here you can see it's a spindle cell tumor, relatively hypercellular, but the cellularity varies. Now you can notice these vessels with perivascular hyalinization. The cells here are even a little bit epithelioid, which sometimes happens in these tumors. A lot of hyalinization in the stroma and around the vessels. Beautiful again here. It was positive for CD34 focally, not diffuse, but some expression was there. So you can, with this morphology, definitely can start wondering about solitary fibrous tumor, which would be compatible with this morphology. But always remember that there are now these kinase fusion positive mesenchymal tumors. This is S100 protein diffuse positivity. And also CD30, just common CD30 antibody is very useful. It's typically positive in these kinase altered tumors, most commonly having NTRK fusions, but more and more are described tumors with other similar alterations such as BRAF or RAF1, RET. And actually this case after sequencing had the RAF1 fusion, which is relatively rare. So now in WHO we have this emerging entity called NTRK rearranged spindle cell neoplasms, which even before it has emerged fully has been proved to be wrong title because they are not always NTRK rearranged, so hopefully it will be altered to something like kinase altered spindle cell neoplasms or something, because very often you have another fusions from different from NTRK. Okay, that's all from my side, Marianne.
I've got a bunch of pretty easy cases. The first one is teenager, and these are biopsies from his nasal cavity and paranasal cavities, and they clinically described polypoid tumorous lesions within nasal and paranasal cavities. And they performed biopsies, and all of the fragments look like this. This is consulted biopsy, so the H&E is not perfect. It's not ours. And you can see quite inconspicuous respiratory type of epithelium at the surface, some inflammatory infiltrate, and then this quite highly cellular stroma with many osteoblasts forming a bone, essentially, okay? And it looks a little bit atypical. It looks almost like very fresh fracture callus, but it's teenager, it's not professional boxer. So the lesion was, I believe, correctly diagnosed by the referring pathologist, and we have just confirmed a diagnosis of benign inflammatory sinonasal polyp with this extensive osseous metaplasia, which is rarely described in these polyps. So please do not mistake this as osteosarcoma or tumorous lesion. So it's very, very rare, and I believe it's my first case. So
Chondromesenchymal hamartoma could be.
yeah,
But it's very young.
Yeah. But I believe it's not.
It's not.
It's metaplastic.
No, exactly.
Metaplastic bone formation. This kid has Bartter syndrome, which is genetically it's inherited condition with polyuria and hypokalemia, and the kid was supplemented by minerals, probably has something to do with it, but I'm not sure. The association with Bartter syndrome was not described in the literature, so it's probably only coincidence. So my next case is older adult patient male, and this is a biopsy from his anal perianal area. And this is already repeated biopsy, and some dermatological conditions were ruled out. And clinically, I saw image of it. It's really a big, bulky mass. I didn't bring the picture with me because you are after the lunch, and the picture was not that beautiful. So I also stained for Treponema pallidum bacilli, but this is only just for really to be pretty sure it's not Condyloma lata, and my diagnosis is because of the presence of these bulbous infiltration border, it's verrucous carcinoma. Okay. So the most frequent site.
What's the site?
It's
of
anus.
anus?
It's anus. So anus is probably the second most common site for this type of cancer, because the most common site are head and neck region. Okay. So you have to correlate it with biopsy. Do not call it reactive or whatever, hyperkeratosis, papillomatosis. It's bullshit. You have to correlate it with the clinical findings, and it was really nasty looking, bulky lesion, and it's verrucous carcinoma. So the lesion will be always P16 negative, HPV negative. Verrucous carcinoma is not associated with HPV infection.
Maybe with 6-11, low risk.
Yeah, maybe sometimes, but this probably also may be coincidence, because most lesions don't show any.
No, it's quite common. I saw it.
Okay.
P16 is negative in these, yeah.
Yeah. This is pancreatic biopsy in older, again, male patient with some, they say it's pancreatic head tumor. It's a little bit thick, but you can see normal pancreas here. In addition, some epithelial structures which look only a little bit atypical, not straightforward malignant case. I'll show you maybe better. Yeah. So there were some epithelial structures, maybe some poorly formed glands, but I was really not sure. Maybe here's something a little bit atypical. In my eyes, this is not sufficient to call it carcinoma. Okay, I'm always cautious about that, because if you call it cancer, it's not cancer. They will operate, do the brutal operation, which has by itself 4 or 5% mortality. So I always stain for some markers. Unfortunately, some markers don't work in our lab, but in this case, find it. These epithelial structures showed P53 positivity, and Ki67 proliferation marker was also highly positive. So I also performed some NGS, and it came back with P53 mutation. No other types of mutations were found, which is funny because I expected it to be KRAS mutated or some other genes. But in combination, this immuno with P53 staining and mutation, I called it eventually as ductal carcinoma. Okay, so this is borderline case, and in our hands, we are able to diagnose these cases correctly as carcinoma in more than 85%. So NGS is very, very good in making diagnosis of pancreatic lesions and biliary tract lesions. My next case is older adult male with a tumor in his small intestine. It was, I believe, something about 9 centimeters big. And yeah, maybe you can see it's small intestinal wall. And then we've got something tumorous here. The tumor showed this funny looking biphasic morphology. The first component looked a little bit hypocellular, cytologically blunt with these lots of collagen fibers, some hyalinized vessels, almost like in schwannoma. Okay. No big atypia here. Not many mitotic figures, but we do not see lymphoid cuff as will be expected in GIT schwannoma. And the second component is here. It was quite cellular, monotonous looking, and there were plenty of mitotic figures. And there was even necrosis focally present. And in some parts showed some funny looking vessels, almost hemangiopericytoma-like branched vessels. Okay, but we are in GIT, lux sarcomatose, and common things are common, so I have performed DOG1 and c-KIT staining first, and it's positive. Okay, so although the morphology was a little bit like solitary fibrosimilar-like, with biphasic, hypocellular, even with staghorn form vessels, as you can see here and there. Okay, so it's still GIST. Okay, so always in GIT mesenchymal lesion, the most probable diagnosis is GIST. So it was, I believe, high risk GIST because of the location, the size, and the number of the mitotic figures. So I expect clinicians to call me and ask for genetic testing to give the patient proper treatment. Okay, another case is a young male patient, and he presented with lower limb or in the gluteal region, big mass. It had almost 10 centimeters in the biggest diameter, and it was in a close relationship with nervus ischiadicus, and was operated by neurosurgeons and sent as a schwannoma. And low magnification is very good in this case, and you can appreciate it's not very cellular, but you can see these hypo and a little bit hypercellular parts. It's a little bit myxoid, maybe. And the cells are not very atypical looking. So I had a couple of differential diagnostic options, but the most important one regarding your immunohistochemistry is MUC4, mucin 4 staining. Okay, so I will go back to this very low or lower magnification. So this is the typical picture you want to see. And MUC4 staining, okay, diffusely positive. So we eventually performed genetic testing, and it came back with prototypical FUS CREB3L2 rearrangement, and the diagnosis is low-grade fibromyxoid sarcoma, or Evans tumor, as we like to call it. So this is by H&E, cytologically relatively blunt lesion. Frequently, you will see it in a small biopsy. You may call it as something benign, but it will be a big mistake, because although the name of the tumor is low grade, it's not low grade. In like many years of follow-up, many lesions come back, especially when excised marginally or with positive margins. And when with positive margins, most patients will eventually die because of recurrences and metastatic spread. So it is very important to examine the resection margins. In this case, the margin was positive, so I recommended local wide re-excision of the lesion. And if initially excised completely, the prognosis is actually quite good. So everything is in the surgeon's hand. So this case was low-grade fibromyxoid sarcoma or Evans tumor. My next case is older female patient, and she had enlarged lymph nodes in her axilla. How many times do we? It's okay. And so axillary lymph nodes enlarged, and they performed this core needle biopsy, and there is something wrong there. And they also told me that the breast parenchyma is clear, is devoid of any lesion. Okay, so it's something very blue, very cellular, and very malignant. Okay, many mitotic figures, many apoptotic bodies, and in my eyes, the morphology is essentially of small cell carcinoma. Okay, and in fact, this was INSM1 staining, so diffuse positivity, nuclear antigen. Okay. And synaptophysin and P16 was positive. So, but we are in axilla, okay? Ki67 was almost 100%. So we are in the axilla, which it may happen to have a metastatic small cell carcinoma from the lung in the axilla, okay? But still, the skin is much closer. So I performed CK7, CK20, and this is actually CK20, which was only focally in 2 or 3 foci positive in this dot-like pattern, which is very typical of Merkel cell carcinoma. And nowadays we have quite very well working antibody for Merkel cell polyoma virus. You don't have to perform genetics, and it was nicely positive. So this is a metastatic Merkel cell carcinoma, small cell carcinoma of the skin. Probably we are done. Okay, so thank you very much for your attention, and see you next week.